trabeculectomy is the surgery for glaucoma, when it has been the surgery for several years, but there is always a time to bring about change, and now is the time. We have a lot of variety of minimally invasive glaucoma surgeries which have their advantages and disadvantages, which have their indications and contraindications, and we will be looking at some of them which are available in India. Many of them are not available in India, so that is also there. So that is why we will be covering from beginning to end what is MIGS, what are the things which are available here, our experiences with Bang, KDB, Tanito Hook, GAT, iStent, and all of these things which are available to you. Okay, so we will start the session. I'll be talking about, I'll be introducing MIGS and intraoperative gonioscopy. So I'm Dr. John David Zakra. I'm a glaucoma, cataract and refractive surgeon at Western Eye Hospital and Chaitanya Eye Hospital in Kochi. Let's first start. Firstly, financial disclosures, no financial interests. What is MIGS? It's micro-invasive or minimally invasive glaucoma surgeries. Here you can see some eye stents, and this is an eye stent W which has a wider base. This is a model of the Kahook dual blade. If you see, okay, yeah, there is no financial interest. If you see, these are all much smaller than they are made out to be, not to scale. And a special thanks to Dr. Prasanna Venkatesh, who is supposed to be presenting here, but unfortunately he had a small accident yesterday, so he won't be presenting. We'll be presenting for him. Special thanks for all his work on MIGS. His presentation is also here, and some of the slides of this are also from Dr. Prasanna. Special thanks to him. So what is MIGS? There's a bunch of glaucoma surgery, the newer glaucoma surgeries, which usually have an ab internal approach, that is from inside, with minimal disruption of the anatomy. So that means even if a MIGS fails, you can still do a trabeculectomy if that is what is required, or a tube surgery if that is what is required. And we try to make it as efficacious as possible. There are various MIGS surgeries which have been attempted. Some of them are less efficacious than others, so we will be looking at that. Have a high safety profile. So that is one of the main advantages compared to trabeculectomy, where you might have hypertonia, you might have risk of infection, you have a lot of other things where you disrupt the anatomy a lot. There's a high safety profile here and the ease of use. Most of the MIGS surgeries are quick, and you can just finish it off at the end of phaco emulsification. You can do it combined as a part of this. So if you ask why MIGS, you look at what patients require MIGS. You look at mild to moderate open angle glaucomas first, and even pseudoexfoliative glaucoma or pigmentary glaucoma, where the block is at the angles. You look at cup disc ratio of less than 0.8, because if it is more, you might need a more aggressive surgery like a trabeculectomy. Preoperative IOP may be up to 30 with medications. Target IOP, you look for something around 15. Don't look for much lower than that. You can take phakic patients or pseudophakic patients. If it's phakic patient, you can do a combined cataract surgery plus MIGS. So you can look at patients who have difficulty taking chronic glaucoma medications with side effects or otherwise, or poor compliance. So all these, like to avoid medication, you can do that. And even with medication, if you want a little more reduction of IOP, and of course the angle anatomy by gonioscopy, you have to look and see that the angles are good before you attempt this. Any of these problems, peripheral synechia, rubiosis, or any angle abnormalities will impair your ability to put a proper MIGS implant or do MIGS surgery. These are some of the MIGS implants and surgeries available. There is a bunch from iStent. So this is the old iStent and the iStent Inject W. We saw these two pictures. iStent Supra, which goes in the suprachoroidal space. Hydrus, which goes into the Schlemm's canal. Cyprus, which goes into the suprachoroidal space. Solex Gold also goes in the suprachoroidal space. And of course, Zen and Preserflow, which go into the subconjunctival space. So this is a hybrid between MIGS and lesser than trabeculectomy. Then there is bent and needle goniotomy, which we'll be talking about, which is probably the most inexpensive, most economical one to start with. Then there is a Cahook dual blade, which is also mostly economical and is an angle surgery. GAT, gonio assisted transluminal trabeculotomy, where you go and de-roof the Schlemm's canal 360 degrees. And this was first done with a catheter, fiber optic catheter, so it was more expensive. Then came the suture GAT, which Dr. Mahesh will be talking about, where it is much less expensive now because we are using a Prolene suture. And there is the trabectome, which again de-roofs the Schlemm's canal. And this one from Otley, high frequency deep sclerotomy, again de-roofs the Schlemm's canal. Ab interno canaloplasties, then Tanito microhook, and streamline. So this is the Cahook dual blade, and this is the iStent injector. These are the ones which are easily available now in India. Before you go into MIGS, you need to know about intraoperative gonioscopy. So you need a direct gonio lens. And to practice, you can maybe start with using a Sinskey hook just to get accustomed to going to and from the angle. A cohesive viscoelastic, which is sodium hyaluronate 1.6%, 1.4, 1.6, both are available. The more the higher concentration is easier to use. And you can use either a handheld Swan Jacob type surgical gonio lens, and you can place it across like this, and the cohesive viscoelastic helps here. And you can also use a TVG lens, which stabilizes the eye as well and gives you more freedom to move around. But there are also hands-free gonio prisms now, which stay with a good cohesive viscoelastic. You put a good cohesive viscoelastic here as well as inside the eye, and that cohesive viscoelastic helps you keep this there without holding it with one hand, freeing up both hands to control the eye. So these three, the hands-free from Catena, the Secure Flex from Ocular, and the Eye Prism SX from Oculus, or from Glaucos. This is from Glaucos. All of them are hands-free. So this is Eye Prism SX from Glaucos staying on top of an eyeball model, and here I think it's a Catena here. This is a Cahook dual blade, and there's also the Oculus Gonio Ready, which attaches to the microscope, which is also slightly more convenient but also more expensive. So that is one option. And Dr. Prasanna will be demonstrating here the positioning. Positioning is you need a tiltable microscope. So you have to tilt the microscope like this. So it's around 30 to 45 degrees. And this is an important tip. You can mark the position so that the assistant can tilt it for you, because once you're scrubbed in, it's difficult. And so once you also need tiltable eyepieces for best option, and also you tilt the patient's head away 30 to 45 degrees. Okay, so that is how you adjust a microscope. This mark is very useful. And tilt the patient's head away and tilt the patient's tilt the microscope towards you. That is how you get to the angle. And you have to reduce the blood coming into the angle. So keep the patient's head above the heart, tilt the OT table to prevent blood reflex from the Schlemm's canal. So if you do this, you will reduce the most common problem with MIGS, that is a blood reflex into the anterior chamber. This is Dr. Prasanna showing the TVG lens. Which is much more expensive but gives more stability, but I think one of these hands-free lenses will be most economical and useful right now. So make sure it is a high highly cohesive, 1.6% sodium hyaluronate, and then once you put it, you can get an angle view. The other presenters will be talking about all these things which are available in India, and you'll get more tips and tricks for MIGS from them. So this, if you see, you can see the angle, and this is how Dr. Prasanna is going towards the angle to show you. Right, this is how he makes the cut. So thank you as an introduction. I will call upon the other speakers now. Dr. Neetu Mohan is the Chief of Glaucoma Services at Arvind Eye Hospital, Chennai. She is a very good teacher, and she will be talking to us about BANG, KDB and Tanito hook. That is the bent angle needle gonioscopy, the Cahook dual blade and the Tanito micro hook. Thank you, Dr.
Good afternoon, and thank you, Dr. John and KSOS for the opportunity to be here today. So I was hoping to be part of this young, vibrant team. One person is missing, but still it's good to be part of a young team. So I'm just trying to share some of the learnings that we have had in the past 1.5 years since we started MIGS. So these 3 surgeries are probably one of the first surgeries that can be tried when you are trying to start MIGS. Of course, as John described, visualizing the anterior chamber angle, surgical gonioscopy, and just getting the feel of going and touching the trabecular meshwork with the Sinski are the initial steps. And after that, once you are comfortable with the visualization, these are probably the first steps that you can take towards MIGS. So we know all these 3 techniques, the KDB, the BANG and Tanito micro hook, essentially addresses the resistance at the level of the trabecular meshwork. And this is where we know there is maximum resistance in open angle glaucomas, in primary open angle glaucoma, and the collector channels are densest in the inferonasal quadrant, which is why all these techniques address the nasal quadrant. So as described, these are best in mild to moderate open angle glaucomas. Having said that, there may be more indications which may be revealed in future, but as of now, we offer this for mild to moderate open angle glaucomas. So this is one concept that we need to understand. This is the episcleral venous fluid wave. So at the end of surgery, if you can actually visualize an episcleral venous fluid wave, which is blanching of the episcleral vessels when you do an AC wash or when you hydrate the chamber, that is an indication that the MIGS may work well in these size. But this, of course, is done only at the end of the surgery, so we don't really know before surgery what are the prognostic factors in terms of outcomes, but this is one thing which will tell you that the MIGS in this patient will probably work well. So coming to the KDB or the Cahook dual blade, this is essentially a handheld knife which is designed to engage, stretch and excise a strip of the trabecular meshwork. It does an excisional goniotomy with less collateral damage to the posterior wall of the Schlemms and the adjacent structures. So the distal tip engages into the Schlemms canal and the trabecular meshwork is elevated onto this ramp that you see here, and it is fed to these dual blades which removes a strip of the trabecular meshwork. So the technique as described, the head over heart will reduce the bleeding into the eye, reverse Trendelenburg position, just 20 to 30 degree head over the heart. And we usually combine it with cataract surgery. After cataract surgery with IOL implantation, intracameral pilomine or carbachol will allow better visualization. Utilize a clear corneal wound from cataract surgery and a cohesive viscoelastic in the anterior chamber to deepen the nasal anterior chamber. Patient's head is rotated 35 degrees 35 degree away from the surgeon, and the microscope as described is rotated 35 degrees towards the surgeon. We also have these positions marked on the microscope, and there are apps available on the Android and on the iPhone. I think on the Android it is angle meter. You can actually mark the normal position in which you operate in and the position that you want for MIGS, so that your assistant can help you to quickly change the positions when you are switching from MIGS to cataract surgery. A cohesive viscoelastic on the cornea. A Catena lens which comes with the Cahook dual blade is what we usually use. A Schwann-Jacob lens will also be good. And as described, the KDB is slid into the Schlemms canal and then you excise a strip of the trabecular meshwork. So essentially there are three approaches to this. One is mark and meet, where you mark the end point of your goniotomy and then you come back and start as far away from that as possible, and you keep moving till you reach your end point. Or you could do outside in, where you start from the extreme as far as you can get on either side and come and meet in the center. Or you could do inside out. Depending upon your comfort level in that particular patient, you can decide which approach you want to do. So this is KDB glide goniotomy in a patient which for some reason did not have much of a bleeding during surgery. So I thought this may be a good one to see the technique well. So it is good to have the microscope foot pedal comfortably positioned so that you can zoom in and out every time you want. Introducing an instrument, better to zoom out once you are focused. This is mark and meet. I am marking the end point of the goniotomy here. And then coming as far I can towards the inferior nasal angle. Slide into the Schlemm's canal. It engages into the Schlemm's canal, and try to keep the focus as you do the goniotomy. I've lost focus here, moving the joystick of the microscope, focusing well, and then engaging. You can see the trabecular meshwork being lifted off, and since it's heavily pigmented, it's very well visualized in this case. The trabecular meshwork is lying over the iris here. Again, changing the focus, focusing well. It's very imperative to have a good focus there. I still don't have it. I'm waiting for that to happen, and then engaging again. And completing the goniotomy. Though I marked the end of the goniotomy, the trabecular meshwork did not really get detached there. So I'm just going back and removing the trabecular meshwork completely from there. Now it is completely detached. It's lying over the iris. I am removing it with a McPherson. So this is KDB, and this is post-op day 30 gonioscopic image of this patient. Sometimes you may have remnants of the trabecular meshwork in some areas, but this is mostly completely done. So what evidence do we have to support the use of KDB? So this is an RCT which compared phaco KDB versus KDB, and they found that at 12 months, in 71% of the phaco KDB group and 68% of the KDB alone group, there was at least a 20% reduction from baseline. But there are also RCTs which have compared KDB phaco versus phaco and found not a very significant drop in IOP, though there was a difference between the phaco KDB and the KDB group. There is a particular RCT which did not find this difference to be statistically significant. And there are a number of retrospective studies which have compared KDB with other MIGS and found comparable outcomes. This is one which compares phaco KDB with phaco iStent and found comparable outcomes. And this is one, this and again a retrospective series in angle closure glaucomas which has found good results. So bent ab interno needle goniectomy is probably the most cost-effective MIGS that can be tried as an initial step when you are learning MIGS. So this uses a 25 gauge needle, the distal 1 millimeter of which is bent towards the bevel about 80 degrees, as you can see here. So it essentially mimics how a KDB looks, and the dorsal portion of the bent needle is supposed to protect the posterior wall of the Schlemm's canal so that it doesn't damage the posterior wall of the Schlemm's canal. And the thickness of this double blade is again titratable depending upon where you bend it. So you can adjust it according to your needs and essentially use it the same way as demonstrated now. Slide into the Schlemm's canal, it engages there, but it's very sharp, so it tends to come out sometimes. It's not as smooth as KDB, and this is usually what happens. There will be a lot of bleeding. So there are very few articles on BANG. This is a retrospective series. I think this is the major article which I could find, in which similar outcomes, about 20% reduction in about 70% plus of the patients, and a reduction in 1 or 2 AGMs have been reported. Tenito microhook ab interno trabeculotomy excises more of the trabecular meshwork. You can achieve almost 2/3 of the circumference of the trabecular meshwork can be removed with 10-2 microhook. There are it's a set of 3 microhooks. You have a straight one, which you can do a trabeculotomy in the nasal angle using the straight one, and there are 2 angled ones which address the temporal angle. So the nasal goniotomy is done with the straight hook, and the angled microhooks are used to do a goniotomy in the temporal angles. So this is the 10-2 microhook. The good thing about the 10-2 microhook is it's blunt. It's not as sharp as the needle that you bend. So it actually goes and engages into the Schlemm's canal. So it is a little more controlled than bang. So you can see it going and engaging into the Schlemm's canal, and you can see the microhook a little bit through the trabecular meshwork. You know you are in the right plane. And here I am doing the inside out technique, and then completing to the other side also. So I have not done beyond the nasal goniotomy with 10-2 microhook. When I want to do more than the nasal angle, I have now started doing GAT. I have been using only the straight microhook. But it is a very controlled goniotomy that you can achieve with 10-2. Again, there are a lot of retrospective studies on 10-2 microhook. This is one series in 560 eyes where the mean IOP reduction reported is 31%. And there are studies which compare microhook trabeculotomy with suture GAT and find comparable, if not better, results. And this is a recent RCT from India in 114 patients. And they found a 50% reduction from baseline in the group which had 10-2 microhook trabeculotomy when compared to phaco alone. And they found that the degree of trabeculotomy that is done did not really correlate with the IOP reduction. So complications, of course, hyphema is there in 90 to 95% of the cases. Some amount of hyphema will be there. Iridodialysis can be a dreaded complication. Long-term complications which are reported include elevated intraocular pressure, PCOS, transient pain, and reoperations for hyphema. My take on this, I feel it is definitely an option that you have to provide for patients with open-angle glaucomas, especially for those whom we are not planning a glaucoma surgery. And in elderly patients and patients with comorbid conditions who find it difficult to use medications, even in advanced glaucomas, I find that patients usually don't mind having an option like this. Patients have to be counseled thoroughly regarding realistic expectations that it is only going to reduce a medication burden. It's not going to take them off medications. Post-operative hyphema is almost always there. Post-op day 1 vision will not be like a cataract surgery. Stop anticoagulants 5 days pre-op. These 3 techniques are essentially similar, though KDB glide and 10-2 microhook seemed a little more predictable in my hands. Just 1 minute, can I take? John? Yeah. Intracameral pilomean helps better visualization. Having the phaco incision exactly at 9 or 3, that helps you access the nasal angle the best. Good visibility is key. Have a good subtenon block given a little earlier before surgery so that the bleeding from that stops. Have a clear corneal incision rather than a limbal incision. Get good control of the microscope foot pedal. Keep zooming in and out as you visualize structures. Use a good cohesive viscoelastic, as already John had mentioned. And we have also found that using the cohesive viscoelastic at the end of surgery also helps to control the hyphemas. So this is what we do at the end of surgery. You keep washing till the bleeding almost completely stops, and then half fill the anterior chamber with the cohesive viscoelastic. Not completely fill it. The eye is still soft. As you can see, the eye is still soft, and then give a good tamponade with saline and form the chamber tightly. So this helps to prevent these dispersed hyphemas which can cause an acute drop in vision, and even if you have a hyphema, it will be more localized like this. So the vision will still not be hand movements and 1/60 which can make the patient panic. So we are seeing some good reduction in IOP, and there is a reduction in medications. The data is yet to be compiled. Literature is currently limited by small sample size, narrow spectrum of glaucomatous disease, and conflicts of interest. We need more evidence, and these techniques are definitely evolving, and there is a lot of future in most of these techniques. and it's definitely a graceful surgery to learn. And I see that in some way or the other, many of these techniques are going to stand the test of time. Thank you.
Thank you so much, ma'am, for your experience on all these types of MIGS. I know you have your vast experience on GAT also. I think Dr. Mahesh will be talking to us about GAT and suture GAT. If at the end of the session, I think we invite questions and discussion on these. So if you have any questions, please note them now. We will have time at the end. Over to you, Dr. Mahesh. He is consultant glaucoma services at Ahalya Foundation, Palakkad. He was my junior in JIPMER, both MBBS and in PG. And he was in LB Prasad. He has done a lot of innovations and worked abroad as well. Over to you, Dr. Mahesh.
Thank you, Dr. John. At the outset, I would like to thank KSOS for the opportunity. And after this elaborate talk on intraoperative gonioscopy, KDB, some intro into eye stent, microhook, the sad part about talking about MIGS being the third speaker is that we have a lot of overlap between this microscope adjustment, patient adjustment, the indications for the surgeries. So I will be talking about what, why, and how of the GAT. In this, I will take you through the introduction to the world of MIGS, introduction to GAT, the intraoperative gonioscopy, the surgical technique, intraoperative complications, post-op management, and also the advantages of the procedure. So as Dr. John has already spoke about MIGS, it was described in 2012 as an ab interno approach. It's minimally traumatic to the target tissue, faster operating time, modest efficacy, high safety profile, and a rapid recovery with minimal detrimental impact on the quality of life. With so many surgical options available for a glaucoma surgeon, whether it is the traditional glaucoma filtration surgeries or the MIGS now, I will be mainly talking about excessive excising or the cleavaging the trabecular meshwork, the GAT procedure. It was developed by Dr. Davinder Grover et al. At the Glaucoma Associates of Texas. It's a non-bleb forming MIGS procedure where the Schlemm's canal is de-roofed. It's a conjunctiva sparing, ab interno, and most importantly 360-degree trabeculotomy. It was initially started as a illuminated catheter-based procedure and now extensively used with the 5-0 proline for developing countries or where socioeconomic considerations are considered. This is the same what I told, the overlap, the microscope rotation. What Dr. Neetu told about the apps that are available in iOS Apple form, you have this measure app where you can keep it at the podium of the microscope and you can measure the angle 30-degree or 45-degree and then mark it. Just a few tips to identify the trab meshwork by the pigmentation of the trabecular meshwork, if it is a PDS case or a PXF glaucoma or post-traumatic. Then you can do actually a provocative gonioscopy by inducing hypotony and causing reflux of blood into the Schlemm's canal and see where the trabecular meshwork is. And also by staining the trabecular meshwork with trypan blue, you can actually identify the trab meshwork in less pigmented trabecular meshworks. The when, how, and why of GAT. Patient selection, most important, should be a cooperative patient. And then there are few contraindications or relative contraindications like cervical spine problems where the patient head cannot be tilted to the required degree to have a good view of the angle. And then bleeding diathesis is when to start with, better to avoid such cases. Or if patient is on antiplatelets, you can ask the patient to stop antiplatelets for 5 days prior to the procedure. Primarily, the indications to start with were primary and secondary open angle glaucoma, and it was done as a standalone procedure or along with cataract extraction. If you want to start any MIGS procedure, better to start on patients whose intraocular pressure is well controlled on more than 2 medications so that you are aim is just to decrease the need for medication and not achieve a better intraocular pressure control. Mild to moderate cases better to start with, but nowadays with increased experience, people even do with severe diseases. Pre-operative gonioscopy, that means office gonioscopy, is an absolute must to rule out any kind of angle closure or any kind of PAS or any kind of neovascularization. These all should be ruled out. And practice few sessions of intraop gonioscopy in a routine cataract case and try to touch the angle with the Sinskey hook as Dr. John mentioned. Preoperatively, in combination with cataract extraction, a detailed consent has to be taken. Discuss the recovery delay. A patient should not have high expectations like our usual cataract surgery. Post-op day 1 I should see 6/6, because as Dr. Neetu said, there can be hyphema and there can be a delayed visual recovery. Discuss the head positioning as against eye stent or a KDB where you see minimal hyphema. Since you are dealing with 360-degree deroofing of Schlemm's canal, you are expected to have a little bit more amount of hyphema in a GAT procedure. So post-operative head positioning with a head end tilted should be discussed with the patient pre-op itself. Now, which to be done first, either cataract surgery or MIGS procedure? There is a well-established scientific basis to tell that it is only the surgeon's choice. There appears to be no significant angle visualization difference whether the surgeon chooses to complete the angle surgery before or after phacoemulsification, and it should rely only on the surgeon preference. When I prefer to do it after the cataract surgery if the cataract is soft. If the cataract is NS3 or 4, I would like to do it before so that my phaco energy doesn't cause corneal edema and impair the angle visualization if I want to do the MIGS procedure later. Intraop positioning as against phaco where your elbows are maintained at the sides and you have a coaxial lighting. Here you have to actually stretch with your, if you are a right-handed surgeon, your left hand should be holding the gonial lens and it will be outstretched. And there will be increased distance between your corneal incision and the angle that you are going to approach. These are the traditional instruments that were needed for a trabeculectomy, and when you compare these instruments with the amount of instruments that are needed for GAT procedures, see the decrease in the amount of clutter. About intraoperative gonioscopy, visco, I prefer to put the visco on the lens so that you have as minimal visco and it doesn't keep spreading over the cornea, and you rest your head either on the forehead when you are doing the right eye, when you are a right-handed surgeon, or on the zygoma for the left eye. Don't use the lens to guide the eye. That means don't use the lens sitting on the cornea to force the eye to guide it to the angle that you want, because that will cause folds on the cornea and will impair your visualization. And as Dr. Neetu said, zoom in, zoom out to the desired area. And this is one good intraop visualization of the angle that you will get if things go fine. Just take into this text now, and when I discuss about the video, I will discuss what I actually mean by these. Avoid limbal vasculature. We don't want blood mixing with our visco and impairing the field of visualization. Usually a 2.2 millimeter incision is sufficient to do a standalone procedure, and if you are opting for a 2.8 or 3.2 millimeter cataract surgery, that also is good enough. A temporal incision is made for the entry of your hook to hold the suture, and this is what tangential incision for the suture entry. Intracameral pilocarpine is used if you are doing a standalone procedure that will make the angle open and also will protect your anterior lens capsule from any kind of injury. Then if you see reflex heme, fill the anterior chamber and keep it firm. And at the end of the surgery, half fill the anterior chamber with visco or air tamponade to decrease any amount of hyphema. So this is a surgery which was done when I was at LVPI, and after getting the visualization, so if you are starting to do cases, better to do your visualization first before starting the surgery at all. Just to confirm that what angle you could visualize in the clinic, you are able to visualize the same at the OT table also. You should not make all the incisions, you have entered everything, you have opened up your gonio lens, you have opened up your suture, everything, and then you are placing and checking the angle, and you are not able to visualize the angle, then all the consumables that you have used are gone waste. So get a view, and then see the orientation of the incision that is made. This is tangential view, tangential incision for introducing the suture. If you make a usual horizontal incision for introducing your proline suture, your suture will lie in the center of the pupil. And taking this suture to your nasal angle and passing it through the deroofed Schlem's canal will cause kinking of your suture, and it will not pass smoothly through the trabecular meshwork. So here we have to have a tangential incision so that the suture will go tangentially like this and approach your nasal angle. So here I have tried to avoid as much as possible limbal vasculature and made it a little anterior corneal incision so that I don't encounter any amount of blood with my visco, which will impair my visualization of the intraoperative angle. This is one thing which we have to keep in mind. Once we place the gonio lens, because of total internal reflection, you see the suture is actually passing from here, but inside the eye the suture is here. You will feel that refraction because of refraction at different levels. You have to get used to it. Otherwise you will go on hitting the cornea and you will cause micro DM detachments. And then have a good incisional goniotomy. I'll just show that once again using an MVR blade. You approach the nasal angle and have a good incisional goniotomy. You see that when I dip it, you can see the deroofed Schlem's canal. Behind that is the Schlem's canal. And now with the use of forceps, this is a ERM peeling forceps or Grieshaber forceps. We hold the suture, which is made bulbous with the help of heat cautery so that it's atraumatic, and then keep passing it along the deroofed Schlem's canal. After almost around 20 to 25 or almost 30 strokes, it passes 360 degree, and you can see the bulbous tip of the 50 proline suture which has traversed all 360 degree and has come here. And the first time that you will see that, it will be a wow moment. You wouldn't be expecting it. You keep on pushing it, and the moment you see it, it will be something you will remember it forever. And once you have seen that, you have to pull it anteriorly and holding the trailing 50 proline with the McPherson forceps, you give traction and see the suture that is moving complete 360 degree. You see the movement of this that is ripping apart the 360 degree trabecular meshwork, and it has come out. This is another case which we did the surgery for a silicone oil filled post VR surgery glaucoma, and you can see this. Actually, I took the patient for trab, and then intraoperatively I tried a gonioscopy and could see the angle very clearly. You can see the oil bubble subconjunctival space, which is actually a risk factor for blood failure. And then I did a 360 degree goniotomy. At 2 weeks, you can see that nicely ripped apart trabecular meshwork, completely open trab meshwork. This is called the cleft that we get after the GAT procedure. Post-op follow-up, hyphema is expected, so we advised head and elevation. Initial post-op day, IOP may be high because of hyphema, the retained viscoelastic that we have put to decrease the hyphema. And depending on the severity of the glaucoma, we usually don't stop all the anti-glaucoma medications on the post-op day 1 itself. And to decrease the initial hyphema and the inflammation, we start the patient on Predfort, and at 1 week post-op, we have shifted over to either low potent topical steroids or even NSAIDs. There was a good discussion sometime back about role of pilocarpine in post MIGS cases to prevent PAS formation, because we are creating raw surface and the iris that is at the periphery going to the raw surface can cause PAS. And it was advised to start pilocarpine at least for 1 month or 2 month post-op to decrease this. But we could see a silver lining during the dark times of COVID, when pilocarpine was not available, and we were doing these cases and we could see that actually nothing of that sort was happening. So we slowly withdrew pilocarpine from the post-op regime. As of advantages of all the MIGS, it achieves 360-degree trabeculotomy. It's a conjunctiva sparing procedure. It's a cost effective as against KDB or eye tract catheter. Learning curve is a little steep, but it is short. These were the few questions that we had to answer when MIGS was introduced. How much IOP decrease? How long? What's the cost? Is it available to us? Is it easy to learn? I think over the years we have done well, and it will test the stand of time. And my take clinic message would be, gonioscopy plays a very important role in perioperative preparation of MIGS, and practice makes a man perfect. GAT is safe, effective, and cost effective MIGS available for Indian scenario. Thank you.
Thank you so much, Dr. Mahesh, on that extensive information about suture GAT. Next is actually Dr. Prasanna Venkatesh Ramesh talk, but since he is not there, I'll be presenting for him. The talk is on iStent, iStent Inject, and the Metaverse MIGSMinimally. So don't go away after the talk, because you will be introduced to the Metaverse with virtual reality, augmented reality headset and all that. The Metaverse person is there sitting at the back. Raise your hand. Yeah, you can experience a Metaverse before you go, okay?
Prasanna Venkatesh.
So if you don't know what the Metaverse is, it is the augmented reality which Mark Zuckerberg talks about. Okay, so this is, we're going on to the talk. This is Dr. Prasanna. So he has done a lot of work on MIGS, as well as a lot of works on teaching and augmented reality and virtual reality. So here we see this on the left here is the old original iStent, and on the right, top right here is the newer iStent, and on the bottom right is the iStent W. That is the one which has that is the iStent W, which has a wider bottom. So we will see why the wider bottom is also there. Okay, so this is Dr. Prasanna Venkatesh details. So he has been to WGC 2019, 2023, and researched on MIGS. And the first few slides are the intro slides, which we have already seen. We will go to the first iStent, that is the first generation iStent, which looks like a snorkel. And here in this series, it has a lumen and a snorkel, and it is a self-defining tip which is engaged into the angle, so into the nasal angle, and this is the injector which is used. Okay, so usually you look for an open angle patient with two anti-glaucoma medications, and this is a typical patient which you will use. And once you make sure of all the findings, okay, so he's doing a cataract surgery with a B-hex pupil expander. So that's a small pupil. So he has put the B-hex pupil expander, and he has gone and just going through the cataract surgery. At the end of surgery, at the end of surgery, you put in the surgical gonio lens. I'm sorry, I'm clicking the button and it's going to the next slide. Yeah. So at the end of the surgery, you position the patient, you put the cohesive viscoelastic, and this is a video where he lost the stent. So if you lose the stent, you can actually with great difficulty you can actually put it back into the injector, because the stent has to be put in with the injector. You cannot just grab it with any other instrument and inject it. So that is one thing. Don't lose the stent. If you lose the stent, it is quite difficult, but you can put it back into the injector and use it. So you can visualize the stent by using gonioscopy. With gonioscopy, you can see the stent in the angle, and you can also use an OCT. So this is an anterior image where you can see the back shadowing at the place where the stent is placed. So this will show you that the stent is perfectly placed. The second generation is what is available right now. So this is a different shape. You have the central outlet at the bottom here, and 3 other outlets here, and at the back there is a central inlet. So this is what is facing the anterior chamber. This goes at the trabecular meshwork. This goes into the canal of Schlemm. Okay, and he has shown in a study that 84% of the eyes in the iStent phaco group were medication free at the 23 months. So that is what his study was. But it is always advisable to put maybe 2 eye stents in the same eye, because with one eye stent the reduction may not be that adequate. And this is an OCT again showing both the stents in place. And this is another prospective study which Prasanna had done of 26 glaucoma patients, and he showed that there was good reduction of IOP, but there is a post-op day 1 spike which will come into effect later, and with number of AGMs, 0 medications, 91% of them were medication free, whereas 46% had 1 medication, 36 had 2 medications, and few more had more medications. And always there is a baseline, and there is a spike which happens before the drop happens. So you have to be aware of the spike, immediate post-operative spike. I'm going to skip these slides about the study, and this is the difference between the iStent and the iStent W. The W has a wider flange here to prevent it from going into the Schlemm's canal completely. The flange prevents it from going more than the recommended amount. And this is a video showing that. If you see, this is the trabecular meshwork, and this is the injector. Once you put it, it goes here. If it pushes a little more, it can go into the Schlemm's canal completely. So then the next version has a wider flange, and after the injector is placed there, the wider flange prevents it from going into the trabecular meshwork too much. Okay, and he had an unusual post-op where patient after MIGS developed Uret-Zavalia syndrome, which usually happens after a very high IOP spike. So it is also possible to have such a complication. And that patient also developed an arcuate RNFL defect. So this is that patient who had an eye stent, but after the surgery he developed Uret-Zavalia syndrome. I think he put only 1 eye stent there. So if you are putting it, you might be recommended to put at least 2. And some glaucoma surgeries can result in Uret-Zavalia syndrome. That was his case report. So in Indian perspective, there is less data from Indian studies, and the replicability of outcomes in India compared to Japan and other places where MIGS, and US, and where the other places where MIGS is more common, is being studied. So we have to be aware of that. And most glaucoma practitioners here, we get advanced cases, whereas the mild and moderate cases may be on medications for a long time. So this is more suitable for mild and moderate cases. And of course, the direct gonioscopy has a learning curve, especially surgical direct gonioscopy. And the procedure itself has a learning curve, and the cost for iStent is quite on the higher side. 42,000 to 95,000 based on the model. And this is a slide where he shows the normal angle followed by the angle after a Kahug dual blade goniotomy, and I think this is a bang. And also I think the other ones where the eye stent was implanted, you get a back shadowing at the angle. Okay, so you see the angles actually open up if you have a good enough anti-segment OCT. So this one he actually calls it the bird beak appearance. Okay, so there's a bird beak appearance, whereas in I think that's a bang, you have some leaflets remaining after surgery, whereas if it's a KDB, you have a wide open angle without any leaflets there. And one of the other MIGS, technically MIGS, is the endocyclophotocoagulation, where you use an ECP machine and you go in with the endoscope, which goes into endoocular endoscope, with which you can see the ciliary body and you can laser the ciliary body. You can cyclophotocoagulate the ciliary body and reduce the aqueous production. So you are tackling not only the outflow, you are tackling the production also directly. And he also suggests there might be a time when we can use compound MIGS, where you actually do cyclophotocoagulation as well as target the outflow with a regular MIGS. So you don't have to go to a trabeculectomy even after that. So this is his opinion on combining trabeculectomy with this one. So this is the compound mix surgery which Dr. Prasanna had attempted. He had put ECP and also he had done KDB Kahug dual blade for the trabecular meshwork. So that would give a much better combined IOP reduction, maybe probably even as good or better than trabeculectomy, since we are tackling the aqueous production as well. Then now we go on to the 4D metaverse, which all of you have been waiting for. The metaverse is here already. There is a virtual reality headset. I'll just talk to you about what it is while the metaverse is being demonstrated. So there is nothing here on the metaverse, but I'll just tell you what it is. It's a virtual reality headset in which you have the Microsoft HoloLens, and once you wear it, you can see the virtual images in front of you in free space, and using your hands as controllers you can grab these models. So it's an eye model of the eye in front of you. You can grab a eye stent or a Kahug dual blade and you can practice the surgery in front of you. So that is what the metaverse is created for. So the most advanced version of this is the headset which you put on. That's a Microsoft HoloLens, so it is quite on the more expensive side. But you can also do a basic version of this using a smartphone with augmented reality. So you have a smartphone with the camera on. You use the Metaverse app. I think it's called MCI app. Yeah, so it's the app which is there from MCI, Mahatma Center for Moving Images. And once you put that app in your phone, through the camera you can see the virtual models in front of you. You can move the camera and go all around it. You can go zoom in to the angle, and you can move around, look at the fundus also, because he has placed fundus images also in that virtual eye. So I think for the next 5 minutes, those who want to try out the metaverse can do so. And this is a list of publications from Dr. Prasanna. Thank you. Any questions from the audience about MIGS? I am sure there are a lot of questions. There are no silly questions. First question, is it micro-invasive or minimally invasive? Yes, somebody raise their hand. Do you have a question? Yes, please. Those who want to see the metaverse, you can go to the back bench. backbenchers can see the metaverse. Frontbenchers can raise their hands and ask questions. Somebody raised their hand but reluctant to ask the questions. Okay, I have a question about
For the sake of discussion, I would ask Mahesh, what is his real indication for GAT? Is it really mild to moderate glaucomas, or do you see them working in more advanced glaucomas too?
Like I mentioned in the indications, when I started with steroid-induced glaucoma, pigmentary glaucoma, POAG, mild to moderate. But over the duration of last 3 years, I have been doing GAT procedure. I have seen, as I showed you, one silicone oil-induced glaucoma where I had given actually, I remember asking John about the name of the drug because I wrote netarsudil for the patient after giving up everything. And the patient checked online and said netarsudil cost around 25,000 or something, because that time I wasn't aware of the name Netalo. That is the Ajanta Pharma's, I think, brand name, which is Indian made. And then the patient's daughter said, if that is going to work, we are ready to get it from abroad also. Then I messaged John and asked, John, what is that netarsudil ka Indian brand name? Then he messaged me. So the patient was on 5 medications and we added pilocarpine also. But then intraoperatively, I tried gonio and I could see the angle and I did that. This patient, even today, even though I have moved out of LVPI, he calls me once in 3 months when he goes for his follow-up and says, on timolol or Dorzox T, my pressure is maintained for 14 millimeters of mercury. So I personally feel there is, whichever patient we take up for trabeculectomy, and if we feel that angle is still open, there is nothing wrong in, giving a trial of MIGS procedure, which might work for 6 months, 1 year, or even 2 years, but that will postpone the need for trabeculectomy.
That has been our experience too, that we have been pleasantly surprised by the results, but the long-term outcomes we are yet to see.
And ma'am, about the high fever, what are some tips to prevent high fever? Because high fever is there in 90%, you said?
Yeah, almost all patients have some amount of hyphema, but what gets you worried is these dispersed hyphemas, where even a blood-tinged aqueous can actually cause a drastic drop in vision. So practically, we feel like Orogel Plus or Helon, half filling the anterior chamber, keeps those as blood clots rather than a dispersed hyphema. So the post-op vision is a little better. I don't know about the long-term outcomes, whether they really impact them, but it is definitely very disconcerting for the patient for a drop in vision from 612 to hand movements. So we have been trying that and it seems to be working.
Thank you, ma'am, for that nice tip. Because patient should not see the hyphema. It doesn't matter if you see the small hyphema, patient should not see the hyphema.
Since I do my GAT before cataract surgery, after implanting the IOL, I don't wash the visco. So I leave that visco which is there.
Do you use cohesive or dispersive for that?
Orogel.
Orogel, yes.
Sir has a question.
Can I ask a question?
Yes.
Like in trabeculectomy, the results are better if you do it quite early, and rather than a scarred conjunctiva having the results are better. MIGS, how is it? Is it better to do MIGS in the beginning stages, or desperate cases where you have put 4 or 5 drops and conjunctiva is all scarred? Any difference in the results? Do you understand my question?
Yes. So as far as the conjunctiva is concerned, we are not worried, but a patient on long-term medications, we would be worried about the patency of the collector channels. So once the collector channels have sclerosed, we don't know how good the outcomes of MIGS are going to be. As mentioned, intraoperatively, if you can see the episcleral fluid wave in the episcleral veins, that tells you that the outcomes may be better, but that only intraop. So we still don't know about this, sir. Actually, we still need evidence to know which are the eyes in which MIGS works well, whether you need to operate on them faster. But probably collector channels being sclerosed, outcomes may be poorer. What do you say?
Also, this question of yours, sir, has given the interest to do aqueous fluorescein studies as a preoperative risk analysis to see how much of the collector channels are available. So, as of now, For me, if you ask, if the angle is open and if the patient's need is to reduce the AGMs, I'll go ahead and do an MIGS. Let it work as long as it is working, and if I have to do a trap after that, it's fine.
So would you do MIGS as a primary procedure even before you start the drops?
No. So, no invasive procedure as long as medicines can take care of it. And a less invasive procedure as MIGS before a more invasive procedure as trabeculectomy.
Yeah, nice presentations actually. I have about 4 years follow-up of GAT actually, GAT and bang. Bang, of course, I do with 32 gauge needle. 32 gauge because KDB knife is actually 250 microns, approximately 32 gauge. So I switch into a 26 gauge needle so to get the length and stiffness. So it almost mimics a Cahox blade. Now 32 gauge needle is also available with the retinal surgeons. They use it for some vitreoretinal step, a longer one. So you can introduce into your 26 gauge needle cramp, and that bend at 80 degrees gives you almost mimics a Cahox blade. That is one. Second is GAT over 4 years. I found the results are very good. 4 years now I have. But now I have shifted to doing only 180 degrees. Yeah, only 180 degrees. Thinking that probably if I need, like when what you do for SLT, you do 180 degrees, you wait, and then you repeat at the same place or the opposite 180 degrees. Similarly, I do for GAT also, where I go, I don't pull it completely halfway through, approximately 180, I'll say, plus or minus 10 degrees, and that is, and thereby your bleeding also is less. And results I felt is almost the same, maybe 10% less, that's all. Thank you so much. Yeah.
Thank you for the comment, sir. Surprisingly, in GAT, when the suture doesn't go as desired and when we abandon, the goniotomy that we have created itself has worked well in few cases. So as when Barwell implant came 350, 250, 500, the bigger the better. We actually don't know how much of angle we need to open to achieve the trabecular meshwork and the IOP reduction. So for me, if I do 360, somewhere collector channels will be there. That will work is my idea. Yeah. Thank you.